We did an X-ray for a burn patient, and this is what you see on the X-ray. What do you see?
Bilateral lung opacities.
Yeah.
Diffuse bilateral infiltrate. In the context of severely burned patients, what do you think?
It could be either fluid overload or it could be ARDS.
Which one's more common?
ARDS.
ARDS, of course. Right, so we have to be careful about the ARDS. So, so let's say, when would you be leaning towards the fluid overload picture?
When it's more on the basis,
Tell me one parameter that you'll look at.
the pulmonary capillary wedge pressure.
We don't have pulmonary capillary wedge pressure.
Oh,
Yeah, we can see the bedwing appearance of the pulmonary edema.
edema.
The fluid overload meaning pulmonary edema. So how would you lean towards the pulmonary edema? That's my question. We
If
don't
the
have
bases are
invasive
involved,
monitoring yet.
if the bases are involved, of the lungs bases are involved.
Not necessarily.
Okay.
The patients may not be sitting upright, right? Many of the patients are sitting upright. That's why if the fluids accumulation happens, it happens for the lower bases. But these patients won't be sitting, so they will be lying. So if it's happens, it's just going to flood the whole lungs as well. So one parameter that you look at would be
Capillary or bedwing appearance.
Say it again.
Capillary or bedwing appearance in the X-ray.
It's very non-specific and very difficult to see on the X-rays. Anyone? In other words, it's included in the diagnosis of the ARDS. Wedge pressure.
Are you saying? I talked about the wedge pressure.
Or we don't have
PaO2 FiO2 ratio.
Bilateral lung infiltrates.
If it happens longer than 1 week, later than 1 week.
All right. So what I'm looking for is the ejection fraction or obvious signs of heart failure. Right?
Oh, okay.
As long as the heart is the pump, as long as the pump is okay, you can load pretty much all the fluids quickly and they won't usually go in the pulmonary edema. If the pump is not okay, then we'll be in trouble. So we'll talk about that in much details when we talk about diagnosis in a minute. Now let's start with what is ARDS or acute respiratory distress syndrome.
It is
non-cardiogenic pulmonary
pulmonary
edema.
edema caused by direct or indirect lung injury and then caused to eventually multi-organ failure due to non-cardiogenic pulmonary edema.
Very good. As you both of you said, non-cardiogenic pulmonary edema, meaning you must rule out the heart problems. That's why if the heart is not okay, I would be leaning towards the pulmonary edema. If the heart is fine, and in this case, the severely burned patients and ARDS. So it's caused by either direct lung injury or indirect, according after secondary to the secondary, a very severe illness. It is the lung damage and the release of inflammatory mediators, leading to increased capillary permeability and non-cardiogenic pulmonary edema and multi-organ failure. This is a classic definition. I don't want you to not only remember the classic definitions, of course, you have to say these in the exam, but I'm going to push you one step further and then tell me why would pancreatitis, for example, leads to ARDS. Pancreas is in the abdomen, way deep in the retroperitoneal space.
Because the cytokine storm.
Inflammatory markers, mediators.
The short answer is the cytokine storm or the inflammatory mediators. It's sudden release, and so much so that it damages the lungs, right? And causes inflammation, capillary permeability, and edema. Or sometimes it could be a direct hit, like, for example, COVID. COVID can cause severe ARDS as well. What are the clinical features?
Cyanosis, tachypnea, fever, cough, pleuritic chest pain, diaphoresis, bilateral crepitations, tachycardia.
That's correct, right? So in short, these are severe signs of respiratory distress. Cyanosis, tachypnea, tachycardia, crackles, fever, cough, chest pain, confusion, diaphoresis, coma, and if you don't treat it, the patient will die. Death. Well, If we are going to take a piece of tissue, look under the microscope, what histological findings are we going to see?
Characteristically, we're going to find the hyaline membrane.
Capillary congestion.
You'll see capillary congestion. You will see hemorrhagic areas,
Are
neutrophilic
hyaline
filtrate.
membranes?
Hyaline membranes are the
Alveolar-
fibrin-rich
Alveolar ducts.
and
Is it hyaline
Uh,
cartilage? That's my
necro-
question.
Mm.
so
Is it hyaline cartilage that we see?
no, it's
No,
they're
no.
hyaline membranes.
Membrane formation.
Fibrin exudate.
Very good. So
Yes.
these are not hyaline cartilages, by the way. That is one of the very confusing point. They call hyaline membranes because these membranes resemble the hyaline cartilage. And these hyaline membranes, in fact, are necrotic epithelial cells, edema fluids, and the neutrophils. So whenever you see the neutrophils, collection of the neutrophils, that tells you
There's inflammation.
what kind of inflammation?
Acute
Acute
inflammation.
inflammation.
Acute inflammation. Very good. What characterizes the chronic inflammation?
Granular
Presence
formation.
of B cells, T cells,
Macrophage.
Macrophage.
Not
macrophages.
macrophages. Macrophages will play a
Yeah.
very
Yeah.
important role together with the neutrophils in the acute inflammation as well. So,
So
in short, if you see the lymphocytes around the inflammation site, that is most likely to be chronic inflammation. If you see the neutrophils, that is the acute inflammation. So histological findings, you'll see the capillary congestion and the edema, both interstitial and intraalveolar. That's why causes fluid accumulation in the alveolar membrane and impairs the gas exchange as well as the causes disruption in the production of the surfactant. We'll talk about that surfactant in the management part in a minute later on. And then it could be hemorrhage or collection of the neutrophils as well. And the most characteristic finding is the presence of hyaline membranes lining the alveolar ducts. That's the fibrin-rich edema fluid and necrotic epithelial cells together with the neutrophils and the other inflammatory cells. How are you going to diagnose the ARDS?
by using the Berlin criteria,
Berlin criteria.
Tell me.
it has to be acute onset, less than 1 week.
And 1 week.
Chest X-ray needs to show bilateral infiltrates, a pulmonary capillary wedge pressure of less than 19, and a refractory hypoxemia, FiO2 ratio of less than 300, I think.
PiO2 to FiO2.
So usually this is not enough for you to just know this one. So what we're going to do is we're going to go through one by one. Before that, how can you rule out the cardiac cause?
The pulmonary capillary wedge pressure
Capillary with pressure.
Or
other signs of heart
pressure
failure.
is a very invasive thing to rule out, right? We can't measure that in all patients, only in very sick or certain patients.
Other signs of heart
One
failure.
blood test to rule out the cardiac cause.
Echo.
Echo.
Cardiac output. Cardiac output.
One blood test. Listen to my
blood test.
one blood test.
BNP.
What is BNP?
Brain
Brain
natriuretic peptide.
And what does it tell you?
That the heart is being overstretched.
What is stretched?
Dilated.
Atrial discharge.
No, ventricles are stretched. If
It's
the
ventricle.
is stretched,
Yeah.
ANP.
ANP will be released. Yeah.
Great. We'll talk about these later on. Great. So the other way is to look at the echo. Right? Again, we're going to go through one by one. So obviously ARDS is an acute thing. So must be within 1 week. The symptoms cannot be present for, let's say, more than weeks, 1 week or months and weeks and months. Next, chest X-ray must show bilateral infiltrates. If it's only one side, then more likely it could be, let's say one lung is quite out, but the other lungs.
Pneumonia.
Pneumonia.
Very good. This is pneumonia, probably severe pneumonia, not the ARDS. Next, from the pulmonary capillary wedge pressure, less than 90 millimeter mercury, or lack of congested heart failure signs. So this is the one that I was asking previously. You have to rule out, most of the time we can't know the wedge pressure, but we can rule out congestive heart failure signs, for example, doing the BNP or the echo. Or if the patient's very sick, then we might as well do the pulmonary catheter, or what's the other name?
Pulmonary
Swan
capillary wedge
catheter.
Swan
Swan
guns.
catheter. We'll talk
Swan
about that in a minute as well.
What clinical signs of heart failure qualify as acceptable here?
For example, tell me.
Like if you have edema, like lower limb edema or something like that. Yeah.
Yeah. Brace JVP
Okay.
and
Right.
pedal edema, lower limb edemas, and the gallop sounds when you listen to it. But these are not very specific, by the way. So we always need to look at the echo or BMP sometimes. So wedge pressure, and how can you measure the wedge pressure?
By inserting a catheter.
Central,
What catheter?
It's called a Swan Ganz catheter.
Gland catheter. And why do we measure the wedge pressure?
It gives us an estimation of the left atria
And why do you want
pressure
to know the left atrial pressure?
because it will be the pressure because it's between the valves, so it's going to be the same from the lungs till the atria.
Okay, I agree. Between the valves, the pressure is the same. So, but why do you need to know the left atrial pressure?
So if the atrial pressure is increased, that means there'll be fluid overload.
What does the left atrial pressure corresponds to?
Preload.
Very
The
good.
preload.
Preload of the
Preload.
Preload of the left.
Yeah, the half.
most of the time, when we want to find out the preload, what do we measure?
Cardiac output. Also.
Preload.
of
Oh,
endoscopically.
sorry. Systemic vascular risk.
No.
Preload. Normally, what do we measure to estimate the preload? We measure the preload of the right ventricle, which is central venous
The
pressure.
CAVP, yeah.
That's why most of the time you would look at the central venous pressure and you correspond. Both of the ventricles will usually correspond to each other, the preload. However, if the patient is very sick, then there is a dissociation. So you have to look at carefully the left ventricle, which is much more important, obviously. Right. So this is the wedge pressure. And most of the time, we don't really measure the wedge pressure because of the damage to the limb parenchyma and stuff. So instead, we can measure the continuous pulmonary artery pressure, which is less accurate, but a few millimeters mercuries won't make much of a difference. So we will continuously measure pulmonary artery pressure. In reality, when you look at the heart, if there is no valves between that, pressure is relatively the same. Meaning, if beyond the aortic valve, that's always 120 over 80 millimeter mercury, although there's a bit of variation until the capillaries. Same thing here. Once there is a right atrial pressure and before the right atrial pressure, meaning in the SVC or the right atrium, the pressure is the same. That's why we put the central venous catheter in the SVC just above the junction, and then that will correspond to the right atrial pressure and the right ventricle pressure, etc., etc. So rather than going through into the left atrium, which we can do it, by the way. By the way, how can we get into the left atrium?
By flow along the blood.
Superior cerebral, subclavian artery.
We're talking about left atrium. Okay, go on, subclavian artery, and then go where?
You can follow it down to the arch of the aorta and then sort of swing around and go up.
So you want to go down the arch of the aorta?
Yeah.
And then go through this
Down the
valve to
ventricle.
the left ventricle, another valve into the left atrium. It is impossible to turn that here.
Oh, I thought if you could turn from the other side to kill, maybe you could do that
We'll
too.
talk about how we could turn this one, because what we're going through is against the flow of the blood. Very, very difficult and impossible to turn. So that's why if we want to go to the left atrium, for example, when do we need access to the left atrium? Tell me one procedure. And the most common procedure, in fact.
It changes the valve.
Well,
Ablation for the atrial fibrillation. Atrial fibrillation is presumed to be causing caused by re-entry circuit around the pulmonary veins. So what the cardiologists do is they go in the left atria and burn around that areas and then try to fix that. That's something called ablation. This way is to go through the veins, either superior vena cava or inferior vena cava. Of course, if we're going to use inferior vena cava, we use which vein? Femoral vein, right? Or subclavian vein or the jugular vein, and then goes through the right atrium to the left atrium through the
ventricle septum. Yeah, the fossa.
Yeah,
fossa
so
valgus.
Fossa or the interventricular septum. And then afterwards, towards the end of the procedure, you can leave it or you can close it with a small plate as well. So that is how we can access the left atrium. Very, very difficult and very invasive. As you can see, you have to puncture the interatrial wall. We don't want to do that. That's fine. But then going in the left atrium, we can go into the pulmonary artery and measure the blood pressure, because from the pulmonary artery all the way to the left atrium, there's no valve, and the pressure will relatively remain the same. So that's why we, in practice, in clinical practice, we only measure the pulmonary artery pressure. That tells you the preload of the left ventricle, which is very important, because if you can determine the preload, to optimize the cardiovascular system, you need to do only 3 steps. In the ITU, you're going to see lots of lines, lots of monitors, thousands of lines and the monitors going, people running around. But cardiovascular system, it all comes down to 3 main principles. 1, optimize the preload. 2, optimize contractility and the rhythm. And 3, optimize the afterload. How do you optimize the preload?
By giving
Fluids.
If the pressure is low, you give fluids. If the pressure is high,
Diuresis.
Diuresis, as simple as that. That's why patients with heart failure, the main treatment is the diuresis. They get spironolactone, testosterone diuretics, or loop diuretics, furosemide. Right? They'll be on lots of diuretics for that. However, keep that in mind. We don't diurese the patients in the acute setting. So I said, hypovolemia is harmful. Hypervolemia is relatively harmful, but we can get it under control if required. So we don't diurese the patients in the acute settings, but in the subacute and the chronic settings, we will diurese the patient. So that's how you optimize the preload. Now, contractility, the rhythm. How do you know the contractility of the heart? How can you know the contractility of the heart?
By
looking at the
cardiac output.
What will tell you the cardiac output?
Procolium.
Schwann-Ganz catheter will tell you the cardiac output. How? It has got at the tip, there is a small saline port where it can infuse the cold saline. And at the tip, again, there is another sensor, and that changes the temperature changes within the blood. And through the equation, it can calculate and estimate the cardiac output. By the way, that is the most accurate cardiac output measurement that we have at the moment. Right? So you can look at the cardiac output through the Schwann-Ganz catheter, or you can ask for an echocardiogram and look at which parameter?
Contractility.
Ejection fraction. What's a normal ejection fraction?
65%.
About 60%. Right? Normally 55 to 60%, 65% would be normal depending on the text and stuff, but 60%. In short, about 60% of the blood comes out from the ventricles, especially the left ventricle during the cardiac cycle. Right? So that's the contractility, and the rhythm, obviously you can see it on the ECG. If the rhythm is very slow, what do?
You have inotropes.
Well, that is not entirely true. Sorry, that's not entirely wrong, by the way. We do use one inotrope for the rhythm. And what would that be? We never use that inotrope except in severe bradycardia.
Yeah, atropine.
Isoprenaline.
Isoprenaline. Atropine is not an inotrope. What?
Yeah,
atropine is
anticholinergic.
Anticholinergic. Great. It blocks the parasympathetic system. It doesn't act on the system per se. So isoprenaline is the inotrope that we use it. We do not normally use it because it causes severe tachycardia. But in this case, this would be one stone, two birds. So we can use the isopronin, but more importantly, what we're going to use.
Dopamine, dopamine.
What do we use? The patient's got bradycardia.
Norepinephrine.
Atropine.
Adrenaline.
No,
Uh,
we can't use the adrenaline to speed up the heart because you're going to cause the MI because you're asking the
Norepinephrine.
heart to work hard as well.
Norepinephrine infusion.
It's not a medication. That's a hint. Pacing. How do we pace? Intravenous pacing. If it continues after a few days, then we ask the cardiologist to come to review the patient. If it's likely to be permanent, then we put the pacemaker in. As simple as that for the slow rhythm. That's why in the first instance, we put the intravenous pacing. They put the pacing wires down the central line. On the right side, they start to pace the heart. Well, secondly,
so pacing is superior than giving an inotrope? I mean, isn't it easier to give an inotrope and monitor that way?
It's easier to get the inotrope, but it is more harmful. Why? Because you're not only increasing the chronotropic effect, you're also increasing the inotropic effect, meaning the heart has to work harder, not faster. And that proves for a weak heart to have myocardial infarction as well.
Okay, thank you.
No problem. Next, if the rhythm is very fast, what do you do?
Like very fast, you mean like shockable rhythm, like VTech?
If it's a shockable rhythm, we'll shock it, obviously. No, it's not shockable. It's a sinus tachy at 140.
You can do a carotid massage.
Well, you can't really continue doing the carotid massage for the next foreseeable future. Patients.
Okay, I thought you were saying for a little while, or the first thing.
Beta blockers.
Oh yeah.
We can start them on the beta blockers, or if required, we can start infusion of the labetalol, for example. So that is how you manage the rhythm. If the rhythm is shockable, as you said, VT or VHAV, you just shock the patient for that. Right. So now we've done the preload, we've done the contractility and the rhythm. The third one is
Afterload.
afterload. What is afterload, by the way?
It's the pressure that the heart has to push against.
It's a resistance. More correct word would be resistance, but the heart
Systemic vascular.
and that is mainly controlled by
vasoconstriction.
Systemic vascular resistance or the peripheral vasoconstriction. Let's say, how do you know if the systemic vascular resistance is high, or how do you know these values? Where would you see these values?
Like a clinical sign or a measurement?
Measurement, actual systemic vascular resistance value. How do you get them? Well, you get them on the monitor, but how do you get them? You get it from the Swan-Ganz catheter as well. Well, that's why Swan-Ganz catheter is the most powerful invasive monitoring device that we've got for the cardiovascular system, because it will tell you all three major parts that you need to optimize. So let's say systemic vascular resistance is very high. What do? You
can give a vasodilator.
Such as?
Hydralazine.
Don't usually use hydralazine. What's the first line?
GTN.
Usually GTN or labetalol, for example, right? Talk about if the patient's already had tachycardia and very high systemic vascular resistance, and we give labetalol. How about if it's very low?
Noradrenaline.
What's that group called?
Pressor.
Pressors groups. NORAD is the most commonly used one. It has got predominant alpha action, meaning that it will cause vasoconstriction. It's got a little bit of beta, non-selective beta action as well, meaning it'll give a bit of inotropic effect as well. That's why NORAD is usually the first line to use it. What's next? What's the other options? Vasoconstriction. We need vasoconstriction. We need the pressors. The other ones, you can use vasopressin, for example, metorominol, and phenylephrine, for example, those sympathomimetic agents, predominantly acting on the alpha receptors as well. So mostly we use NORAD and vasopressin. Metorominol, we don't usually use it in the ITU settings. We mainly use it in the cardiopulmonary bypass and such, right? So once you have optimized step by step, that's all you need to know. And that's all they are trying to do in the ITU as well. Next time when you go to the ITU, one, they're trying to optimize the cardiovascular systems. These are the simple steps. Everything that they do, thousands of lines in the monitors, comes down to these three main principles. And all three areas, the Swan-Ganz catheter will tell you what's happening there. That's why in very sick patients with hemodynamic instability, we have to ask for the Swan-Ganz catheter or pulmonary artery catheterization. However, the reason that I said very sick patient is because this is not a benign catheter. As you can see, it goes through, I'm not sure why it's going to the left, but usually to the right, jugular, and then the brachiocephalic vein, and then superior vena cava, goes to the right atrium, goes through the tricuspid valve into the right ventricle, and then comes back out through the pulmonary valve into the pulmonary artery, usually goes into one of the smaller branches and inflates the balloon at the tip, and that causing wedge, meaning that's more accurate pressure because you are blocking the pressure coming from the back, rather measuring the pressure front, which is equivalent to the left ventricle pressure. Again, it's a bit harmful for the lung parenchyma, sometimes can cause quite problematic. So we don't usually leave the balloon inflated for a long time. Rather, we just monitor the pulmonary artery pressure, which is kind of like corresponds to the left atrial pressure as well. So how does this catheter turns around 120 here?
Using the blood flow maybe and an ultrasound echo probe, you can just tell.
But it won't just turn on its own.
Mm.
Anyone? And why would, let's say, have you ever heard of, let's float.
A magnet? Can we use a magnet?
We don't use a magnet either. Have you ever heard of float? Let's float Swan-Ganz catheter. Let's float a pulmonary artery catheter.
Okay.
So the wood, especially if you walk with the old school anesthetists, they would say, okay, let's float one. What they're saying is once this passes through the tricuspid valve, of course you can see pressure tracing, these are different ones, but I'm not going to go into that, right? Once you are in the right ventricle, you go through a little bit more, and then you can inflate the balloon at the tip. Inflating of the balloon, meaning that balloon is filled with air, and that balloon is carried along the blood flow. And that is the word where it's coming from. Let's float a Swan-Ganz catheter. So you can see it is quite invasive and it has got serious complications, including the rupture of the right atrium, for example, or even the right ventricle, because the right side of the heart, as you remember, is much thinner compared to the left side of the heart as well. So that's why we only do Swan-Ganz catheter in very, very sick patients, but Swan-Ganz catheter is a must if you want to, if you're struggling with, let's say, hemodynamic system of a patient. So coming back here, so you know everything about the wedge pressure and the lack of congestive heart failure signs, because it's very important to rule that out, to say this is ARDS. And next is the refractory hypoxemia, meaning PaO2. This is the partial pressure of the oxygen inside the blood. FiO2 is the partial pressure of the oxygen, usually. Well, it's not the partial pressure, but it's the percentage of the oxygen, fraction of the oxygen. That is Fi stand for. Fraction of the inspiratory oxygen in the air, that is usually about
21% if it's room air.
It's about 20%, 20-21% in the room air. And then we can increase it as we go along. So if the ratio is less than 200, that is likely to be ERDS. 300 is very mild and you may not even notice, or you may not even start to have the effects on the patient, maybe a bit and more, but less than 100 is very severe, meaning refractory hypoxemia is one of the criteria. So Berlin criteria, Berlin definition, all of these four must be present to say this is acute respiratory distress syndrome. So the next question is, how are we going to manage it?
So the basis of management for ARDS is early respiratory control. So you're going to use an early CPAP for a positive and mechanical ventilation or CPAP with low volume.
So I said 99.9%. The answer is
A, B, C,
Secret.
D.
A,
ABC.
B,
Right.
definitely.
Okay.
As per secret protocol, right? If it's,
Mm.
for example, this is a pancreatitis case. If it's a pancreatitis case, then we'll say secret protocol. If it's a continuation of the burn patient, then we'll say ATS protocol. But do not forget that part. Right? And then if the examiner will push you further, obviously, and okay, tell me specific managements.
So your respiratory support with early CPAP or mechanical ventilation with a low volume, low to moderate PEEP and a high rate. PEEP of around 5 to 8 or 10 is accepted. As cardiovascular support with the Swan-Ganz catheter and arterial line fluid replacements. We can have
I'm going to
renal.
talk here briefly. What is
Yeah.
5 to 10 PEEP? What's the unit?
CM of water.
Very good. That is the only centimeter water unit, right? The PEEP is measured in the centimeter water. The rest of the pressures that we're going to talk about are in millimeter mercury. Very good. So let's quickly go through it. What you said is perfectly correct, but we need to know why. Right? Let's start with the respiratory support. So always, again, whenever you ask about the management of a very sick patient, starts with A2E assessment as per secret or the ATS protocol as appropriate as per the scenario. And then respiratory support, obviously, this is the respiratory problem. So we have to aggressively monitor and start the early CPAP. If you're very lucky, you may get away with the early CPAP, but that's only a small fraction of the patients. Many of the patients with a full-blown ARDS will need intubation and mechanical ventilation. So that's why if you are worried about a patient who is having ARDS, where do you manage the patient?
In the ITU.
ITU.
Can you manage the patient in the HTU?
No.
No.
Usually not. Why?
Multi-organ failure. Multi-organ involvement. Multi-system involvement.
Because of the high chance for requirement of
The ventilatory support.
Ventilation.
mechanical ventilation, advanced ventilatory support, which is only possible inside the ITU, not in the HTU. Right. So mechanical ventilation, what we're going to do is that with low tidal volume. Why low tidal volume? What's the tidal volume, by the way?
It's the amount of air you breathe every breath.
Very good. Amount of air you breathe in and out. That's a tidal volume. Why low tidal volume?
Because they're overloaded with fluid.
What if you give high tidal volume? What's going to happen?
You might end up damaging it.
Trauma.
Ventilator-associated lung. It's not barotrauma. It is the ventilator-associated lung injury. Barotrauma, the true barotrauma is related to the pressure, right? Higher pressure, not the volume. Don't get confused between the volume and the pressure. Next, low or moderate PEEP. So first of all, we need to know what PEEP is. PEEP written here is positive and pressure. Usually it's 5 centimeter water. Again, PEEP, respiratory pressures, usually centimeter water, don't get confused. This is the only centimeter water that you need to know for the purpose of the MRCS exam. Reduces walk of breathing, prevent alveolar collapse, recruitment of the alveoli, blah, blah, blah. This is from the textbook. Which I want you to know is the understanding of down to the core, not memorizing the textbook. So what is PEEP? Tell me.
You want me to explain this?
Yes, sir. Positive and respiratory pressure in the sense that the pressure is continuous, at least as low as 5 centimeters of water, to ensure that the alveoli are all open, and it's not at every point that we have to blow up the alveoli from 0.0. So it reduces the energy, the effort of recruiting fresh alveoli at every point. So keeping a good number of alveoli open at all times.
Great. So the usual example I give is all of us, we have blown balloons, right? Remember blowing balloons in the party when we're young, right? When you start blowing the balloon, which part is the hardest?
The start.
The start. Just before the balloon starts to inflate, that's the hardest part that you have to blow in. Once the balloon starts to inflate, you can easily blow it into that, right? Alveoli, I want you to imagine the alveoli as the balloons, but in this case, there are millions and billions, even billions of balloons in the lungs. And all of these balloons, if you let them deflate completely, the next cycle, you have to use higher pressure of the from the ventilator to open them. And there is a side effect because high pressure means you're going to damage the lungs and causing ventilator-associated lung injury, which we don't want to do it. So you could ask me, okay, why don't in a normal person, why don't we need a PEEP?
Because the anatomical, I think it keeps them open. The surfactant keeps them
Surfactant.
open.
Very
So
good.
yeah, so you
Surfactant
don't.
is the key factor in keeping the alveoli open. So in a normal person, it's not a problem because we've got surfactant. But when there is severe inflammation, it impairs, and there is very little or no surfactant. As a result, the alveoli will collapse. So rather than trying to push high pressure with each respiratory cycle every about 12 to 16 per minute, what we're going to do is we will leave pressure a little bit towards the end of expiration so that the alveoli will not go all the way to collapse. We'll leave it a little bit open. So the next cycle, we're going to bypass the first harder phase. That will, one, prevent alveolar collapse, and two, recruitment of alveoli, meaning more alveoli will participate in the gas exchange, and that will drive up PaO2, meaning the partial pressure of the oxygen as well. So PEEP concept is very, very important. And
will giving surfactant help this patient?
Yes, of course. But
Okay.
how are we going to deliver surfactant to millions and billions of alveoli?
Fair
So
enough.
it's virtually impossible. So that's why we don't use the surfactant as one of the treatments. So we let the alveoli rest and recover from the inflammation. Once that's done, then they will start producing surfactant again. So low or moderate PEEP, because high PEEPs can kill the patient. Why? That's why I usually say if you're not sure what you're doing, you shouldn't exceed 8 centimeter water or maximum of 10. Be above 10 centimeter water, the patient could go into hemodynamic collapse, cardiac arrest, and die there. Why? High PEEPs are very dangerous.
Tension pneumothorax.
Say again?
It will cause a tension pneumothorax? No.
Not necessarily, as long as there is no hole. Assuming there is no lung damage, there is no hole, it's not going to cause. How is the air going to leak into the pleural space? We're just blowing air into the lungs. If there's a hole, you damage the lungs and there's a rupture of the lungs, then yes, that can lead to the air into the pleural space, sooner or later causing tension pneumothorax. But assuming it's not the case, even without complications.
So does it impair the diffusion of oxygen across the membrane if it's
It
the
will
pressure is
in fact improve the oxygen.
like the carbon dioxide won't come back though?
Not necessarily.
No.
The higher the pressure inside, the more carbon dioxide will come back up.
But you're pushing from outside, right? So
okay. But
so
it's going to cause the
less.
washout anyway. So again, what I said is don't confuse between the pressure and the volume. So what we are maintaining high pressure inside doesn't necessarily mean we need to blow a lot more volume in it.
Okay.
So why would high PEEPs are very dangerous? I'm not talking about dangerous, but I'm talking about life-threatening dangerous. Anyone? The answer is obstructive shock. What is it? What is obstructive shock? Why would tension pneumothorax kill the patient? Same principle.
It would affect the cardiovenous return or the preload.
So what?
So the heart won't pump properly. There won't be enough blood to
Nothing wrong with the heart, so the heart will pump, okay.
No, I mean like there's nothing coming in to.
Very good. So obstructive shock, it will lead to the obstructive shock. As I always say, the blood is the fluid. Like all the fluids and the gases, it flows from higher pressure to lower pressure. Normally, the veins are about 20, 30 millimeter mercury, slightly higher in some cases. And then the atria is about 10 or 20. Then the difference drives the venous return. The blood flows back into the chest. And During inspiration, there's a drop in intrathoracic pressure as well, and that helps the venous return the blood to come back out. However, if you start to increase the intrathoracic pressure, regardless of whether it's inside the lungs or outside the lungs in the pleural cavity, outside the lungs and pleural cavity is the tension pneumothorax case. High PEEP in this case is raising the pressure inside the lungs. Yet, same principle, the intrathoracic pressure goes up. If the intrathoracic pressure goes up to, let's say, 30 millimeter mercury, there won't be any blood coming back to the heart. The heart will be pumping okay because there's nothing wrong with the heart. So nothing fills the heart, so nothing comes out of the heart, and that causes obstructive shock. That is the very same principle with the tension pneumothorax, for example. That's why tension pneumothorax, you have to act aggressively. Otherwise, the patients will die because no blood's coming back. It's very high tension, this time outside the lungs in the pleural cavity. So that's why high PEEPs are very dangerous. However, sometimes it's useful, especially let's say after thoracic surgery or cardiac surgery, there's a little bit of bleeding inside the chest wall. What we can do is something called tamponade effect. We increase the PEEP a little bit more, let's say to 7, 8 cm water, and then press the lens parenchyma against the bleeding side, and boom, you don't need to do it after a few, after an hour or so, then bleeding stops, for example. You don't need to open up the patients again. So high PEEP is, that's why very dangerous, because it can lead to obstructive shock, hemodynamic compromise, and collapse of the patients later on. So next is the mechanical. While we are talking about mechanical ventilation, we'll talk about complications as well. So the patient can end up having ventilator-associated pneumonia or nosocomial infections. That is something that acquired inside the hospital, like sinusitis, line sepsis, etc. Irritations if you're left for days and weeks, ulcerations, and gastric content aspirations, and barotrauma. True barotrauma nowadays is very rare because of the ventilators now have very good sensors inside it. So the true barotraumas nowadays are very rare. That is
also vocal cord trauma if you leave the ETT in for too long.
Say again?
Vocal cord trauma if you leave the ETT in. Yeah.
Of course. What? So and all the traumas all the way down to the related things. So again, gastric content aspiration is relatively nowadays less common as well because of
the balloon and the inflatable ETTs.
There's a cuff around the endotracheal intubation tube. So that cuff is inflated and then anchors against the tracheal wall and prevents aspiration. But regardless, a small content still go down and such as well. So cardiovascular system support, as we said, Swan-Ganz catheter, we have extensively talked about it, so I'm not going to go through it again. Very, very important. If you see a very sick patient who starts to struggle with the hemodynamic system, ask for a Swan-Ganz catheter. It will tell you the preload, contractility, and the afterload. Just need to optimize one by one, and that's it. That's all we need to do. The outline, arterial line, why do we need it?
To get repeated ABGs.
One is sampling. We don't want to puncture it again and again. It will lead to
thrombosis
in the long term.
Stenosis.
Pseudoaneurysms, not pseudocyst, right? Pseudoaneurysms, but yes, that's the same thing. So pseudoaneurysms, trauma, thrombosis, so very, very dangerous, especially if the collateral circuit is not adequate. Then the patients might even lose the limb. So what else? One is sampling.
It's live BP measurement.
Invasive blood pressure management. Sorry, measurement. Why do we need to measure blood pressure invasively?
I mean, if you're giving vasopressors or something, the responses are usually very, very fast. So if you have live measurements, it makes your life easier.
Very good. So invasive blood pressure management is one slightly more accurate compared to the traditional cuff, but as long as you're using the cuff correctly, that's more or less the same. But if it's more or less the same, why do we use invasive one? The reason is when you use the vasoactive substances like inotropes, crosses, the change occurs in a fraction of a second. It's not even a second, it's a fraction of a second. And you have to act quite rapidly, change the dose quite rapidly. And how long does it take to inflate and deflate the cuff and tell you the blood pressure, non-invasive blood pressure?
At least a minute.
It's about a minute, and you don't have a minute, believe me. Well, that's why outline is a mandatory in the ITU. And how often do we take blood gas for a sick patient?
Daily or even sometimes twice a day.
Again,
Lots of times in, you know,
what do you mean by lots of times?
it depends on the patient, I
hour.
guess.
Tell me exact number a day will be 24 because we take it every hour. Of course, if required, we can take more, but routine monitoring of a sick patient in the ITU involved hourly blood gas, hourly ventilator settings and adjustments, hourly observations, hourly drain outputs and fluid balances. And if the patient's on filtration, hemofiltration, for example, then we have to record these usually hourly. If required, then we will go down to shorter intervals, but usually it's hourly in the ITU. We'll talk about the HT and the ward settings later on in another station. Then the fluid replacement, as we talk about it. And if the renals shut down, then renal replacement therapy, which comprises hemodialysis and hemofiltration. In the acute settings, we tend to do the hemofiltration more. Hemodialysis focuses on removing the fluid volume, which is more commonly used in the community settings, which is slightly cheaper. But in the ITU, hemofiltration, which focuses on removing the solutes. So there is a small difference between hemodialysis and hemofiltration, but more or less the same. It is the same. For in the ITU settings, we almost always use hemofiltration. Regardless, that collective term is called renal replacement therapy. That's usually the last stop for the renals. Then if the patient's in sepsis, obviously we'll start the antibiotics, and nutrition will always go with the enteral, required parenteral nutrition. What are the complications and prognosis for the ARDS?
So it has about a 50%, 30 to 50% mortality rate. And complications could be anything from pulmonary complications like lung functions, abnormal lung functions, or pulmonary fibrosis. It could be, sometimes they have cognitive impairment. Some patients have muscle weaknesses, joint problems, neuropathies.
Right.
That's all I can remember.
If you imagine a person staying in the ITU for weeks or sometimes months, what would you expect? Mortality is very high, 30% to 50%, meaning 1 in 3 patients to 1 in 2 patients will die. We're talking about severe ARDS, obviously. Muscle weakness, neuropathy, joint disorders, chronic pain, and cognitive impairment, delirium, fairly common in the ITU. And if the patient survives, they may end up having post-traumatic stress disorder because it is not a very pleasant situation that you've encountered, or lifelong major depressions that we're talking about. And lung
aren't these patients like put to sleep?
They are sedated, but they are not necessarily always asleep. What we don't want to do is even intubated patients, some of the intubated patients, we wake them up. And then if required, we will sedate them. But some of the intubated patients, and especially when the intubations required long-term, we don't leave intubated. What do we do?
Tracheostomy.
Very good, tracheostomy. And what is the duration that we usually convert to tracheostomy?
5 days or a week?
3 weeks.
5 days to a week.
About a week to 10 days. But not 5 weeks, that's too long. Unless there is a certain reason that you can't do that, obviously. So if the patient's relatively okay, but cannot be weaned off the ventilator for certain reasons, then we'll start considering about the tracheostomy after a week or so, about 7 to 10 days, and then we'll convert to tracheostomy. And once tracheostomy, then the patient will be awake and then start doing the stuff as well. So many of the patients, long-term patients, they will be aware that they are staying in the ITU. So they've got these neuropsychiatric disorders as well. For the lung function itself, the volumes are quickly recovered within 6 months, but diffusion may take up to 5 years, especially with the fibrosis and stuff. Great. So that is pretty much for the acute respiratory distress syndrome. Do you have any questions?